Hi, my name is Dr. Vivek Gupta and one of the interventional and structural cardiologists. I work out of Peninsula Heart Center and mainly based at Peninsula Private and Frankston Hospital. I specialize in doing coronary intervention, but also dabble in structural work such as TAVI and left atrial appendage occluder devices. Coronary angiography is a minimally invasive cardiology procedure that basically uses involvement of X-ray imaging to take pictures and obtain information regarding the narrowing as well as the blockages of the blood vessels that supply the heart. It usually is the gold standard and in certain cases is the first choice of investigation, especially in patients with acute coronary syndrome. Coronary angiography is a day procedure that usually involves patients coming in to the catheterization lab on the day, and after mild sedation, an access is obtained either using radial artery or a femoral artery. In this current day and age, radial artery is the commonest site of access. However, in certain patients, especially the ones who have had previous coronary artery bypass surgery, you might notice that femoral access is the first choice of access. A catheter such as this, which come in different shapes and sizes, is then threaded up the blood vessel. Once the aortic root is reached, we try and obtain access of the different coronary arteries. A dye is then injected and series of X-ray images are taken to obtain views of the arteries in different projections. It usually can take up to half an hour to complete a procedure. However, sometimes it can take a bit longer if further evaluation of the vessel is required. Coronary angiogram is usually preferred choice of investigation when a patient presents with acute coronary syndrome. In certain conditions such as a STEMI, it is very time critical and the patient needs a coronary angiography within 90 minutes, having trying to re-establish blood flow in the vessel within that time period. Having said that, there are patients who then present with non-STEMI, where we try and perform a coronary angiography within the first 48 to 72 hours of presentation. There are certain other indications where a patient might need an elective coronary angiography. These include patients who have had valvular heart disease and need workup for surgery, or patients who have had classical angina. This is on the background of having multiple cardiovascular risk factors. These patients, however, might warrant further testing prior. These tests involve either an exercise treadmill ECG, or a stress echocardiogram, a nuclear stress test, or a CT coronary angiogram. The decision is made by the clinician as to which would be the best choice of investigation, and a lot of factors play a role, including patient's ability to mobilize or their comorbidities. We might have to do more than one modality of investigation prior to subjecting a patient to a coronary angiography, and the rationale being a coronary angiography is an invasive procedure and it has its risks, such as stroke and a heart attack. Once the patient's had the coronary angiography, we then try and identify lesions, and sometimes they are critical and warrant treatment in the form of percutaneous intervention. A percutaneous intervention is a non-surgical cardiac procedure which is minimally invasive and involves placing either a stent or a specialized balloon, either plain or a drug-coated balloon, across a blockage. The intended purpose is to open up the blood vessel to maximize the flow and thus assist with patient symptoms. Once a lesion is deemed appropriate either anatomically or functionally, we then proceed with percutaneous intervention in the form of stenting. This involves a series of steps. The first is to position a sturdier catheter across at the origin of the artery. A very thin guide wire is then positioned across the lesion. The next step is the pre-dilatation, which involves positioning a catheter with a balloon tip across the narrowing, and the balloon is then inflated. Following this, a stent, which is then crimped onto the balloon, is then positioned across the lesion. The next step is the post-dilatation, where a more sturdier balloon is used to ensure that the stent is well expanded and opposed to the vessel wall. The intended purpose of this is to ensure that we maximize the blood flow, and this way we can then ensure that the patient feels much better at the end of the procedure. Post the stenting, patients tend to receive up to 12 months of dual antiplatelet therapy. However, in certain conditions, we might have to trim it down to a lesser duration. A lot of factors play a role in making that decision. This includes patient age, their comorbidities, including their frailty, or the fact that they might warrant a surgery in the near future. As a physician involved with the patient's regular care, it is imperative that you contact the interventional cardiologist involved to ascertain the duration of the second agent, especially in cases when they have issues such as bleeding on the two agents. Once the patient has received stenting, onus of care is obviously shared between the interventional cardiologist and you. It is important to identify features of early stent failure, and the patient might present to you with symptoms of chest pain or worsening breathlessness, usually noticed within 4 to 6 months after the stenting. In these cases, it is important that you contact the cardiologist as they might warrant further testing. To ensure the longevity of the stent, it is also important that the patient adhere to risk factor modification, and that's where it is an important aspect of care that you would be able to assist with. This involves managing the risk factors such as diabetes, cholesterol, and blood pressure. Depending on the indication, a percutaneous intervention might be offered to a patient, especially if a patient presents with acute coronary syndrome. The lesion is then treated on the spot. Sometimes you might have to, however, defer the treatment, either depending on the renal function of the patient. In patients with stable angina, it is important to then try and ascertain the anatomical and a functional significance of a lesion. Our definition of anatomical significance is something that is more than 70% in a major vessel, mainly involving in the proximal or the mid segment. If, however, we find a lesion which is significant anatomically, however involves a small branch or the distal segment of a vessel, it is important to obtain the functional significance of a lesion. This could either be in the form of a stress test that has been done before in the same territory, or what we call as an FFR, or fractional flow reserve. FFR, or the fractional flow reserve, is currently the gold standard to determine if a particular stenosis is responsible for any inducible ischemia, especially when it involves non-significant territory such as distal vessel or a small branch. It measures the pressure difference across the lesion and is usually defined as the maximal blood flow across the lesion versus the theoretical maximal normal blood flow in the same distribution. Now, sometimes in an angiogram report that you might notice there are FFRs which come as a ratio. Usually a ratio of 0.8 to 1 is considered within normal range, and in these cases percutaneous intervention is deferred. However, an FFR of 0.79 or less is considered critical and warrants intervention in the form of stenting. Having said that, there are other assessments in the form of IFR or RFR where the ratio changes, and in these cases you might notice 0.89 and below is something that warrants stenting. It is not only important to then ascertain the functional significance, but sometimes you might want to also ascertain more information regarding the anatomical significance of a lesion. And in these cases, I tend to use different modalities of imaging, and these include IVUS or intravascular ultrasound and OCT or optical coherence tomography. IVUS is a catheter-based intervention which involves positioning a miniaturized ultrasound probe at the lesion, and it gives us important information about the inside of the vessel in a real-time view. It helps us ascertain not only the degree of severity but also the nature of the atheroma, which then helps us make the decision regarding stenting. It is also a very useful tool to ascertain stent apposition and stent expansion, especially when involving areas such as left main or proximal LAD, where it becomes very critical. Sometimes we have patients who then present with early stent failure in the form of stent thrombosis or early in-stent restenosis. And once again, I use these investigations to ascertain the nature of stent failure so as to correct them and treat the patient accordingly. This is all the information that is needed for coronary angiography and percutaneous intervention. I believe it would be important to then try and identify patients who might present to you in the form of chest pain or breathlessness that warrants further intervention or investigations. If you come across patients that have chest pain or breathlessness and warrant further investigations, we welcome you to send them across to us at Peninsula Heart Center, where we will then organize for the follow-up investigations.